only 24 subjects had no contamination of the case or lens out of 115. So this is a fairly high rate. The positive contamination, staff epidemic causes very aggressive keratitis. Regarding univariable analysis, Staph aureus contamination was associated with contact lens change interval of more than 1 month and duration of wear more than 6 hours per day. Staph epidermidis contamination was associated with solution change frequency. The more you keep the solution until change it with a new one, the higher the risk of contamination. This is, remember, on univariable analysis. Pseudomonas aeruginosa on univariable analysis, most of the predictors were significant. For example, regarding both contact lens and case contamination, it was associated with younger age group, with longer interval to have a new contact lens, and the type of the solution. Bottled water, distilled water was more significantly associated with contamination compared to commercially available water regarding both the lenses and the cases. Also, the solution change frequency. E. coli was associated with contact lens change interval only. This is again on univariable analysis. We still haven't done multivariable analysis. Klebsiella pneumoniae contamination here, it was only of the cases. It was associated with older age group. See, the proportion older age group was a risk factor. And this table summarizes the findings on multivariable analysis. So here we get the adjusted odds ratio, the real odds ratio, because we have accounted for the confounding variables. We see that regarding gram-positive bacteria, none of which have significant association on univariable and multivariable analysis. However, Pseudomonas aeruginosa associated with both the lens and the lens and the case was associated with younger age group, approximately 12 and 6 times, increasing the risk. Also, it was associated with the use of bottled water as compared to commercially available water or solution, distilled water. Also, when we compare it to commercially available solution, regarding both the cases and the lens. Also, the lens, the case, was associated with solution change frequency. And if we see here that solution change frequency regarding the contact lens contamination almost reached statistical significance. E. coli contamination had no significant association. Klebsiella pneumoniae, again, on multivariable analysis was associated with older age group. So our study results demonstrate a really high rate of contamination of both the contact lenses and the cases among asymptomatic female medical students in south of Iraq. And most of the participants had at least one contaminated item. Previous studies in different climates have reported overall rate ranging from 17 to 52%. For example, studies from nearby countries, from East Asia, also demonstrated some high rate. For example, this study from Pakistan demonstrated a high case contamination. It is also of note here that case contamination was higher than lens contamination among different studies, which is also true for our study. So none of the gram-positive bacteria that were identified demonstrate any association with any predictor analyzed on multivariable analysis, despite reaching statistical significance on univariable analysis. However, gram-negative bacterial contamination, particularly Pseudomonas aeruginosa, had been associated with several predictors. It is known that Pseudomonas is the most common cause of contact-related aggressive bacterial keratitis. Consequently, identification and addressing of the risk factors involved in increasing the rate of Pseudomonas contamination could potentially decrease the incidence of such aggressive forms of keratitis. Poor hygienic practices were present among our study population. For example, wetting of the contact lens with saliva before applying it to the eye in at least one participant. And this risk associated with this practice has been explained thoroughly, and proper hygienic practices had been demonstrated. Commercially available solutions were less likely to harbor contaminations. Of course, this is more logical because they are preserved. They contain preservatives, unlike bottled water and distilled water. Association probably could be explained regarding Pseudomonas that younger age group probably they have less sufficient educational motivation or less care regarding their contact lenses. Our study limitations include the limited number of contaminated samples per some species identified, which could contribute to lack of statistical significance in certain aspects. In conclusion, microbial contamination rate of the soft contact lenses and their cases is high among medical students, and several poor hygienic practices and wearing regimes that were predisposed for it were identified. From this high rate of contamination owing to poor hygiene practices. So these are medical students. They are supposed to be more careful regarding their lenses, regarding the general population. So what if we do the study in the general population? Probably we could find a much higher rate, a much poorer hygienic practice. Thank you.
شكرا جزيلا دكتور لوي. The next speaker is Dr. Juhud Abdul Samad Maulan. She is a family physician. She is going to present the results of her study, which is entitled Barriers to Utilization of Antenatal Care Services at the Primary Health Care Level in the Rural Areas of Basra.
Assalamu alaikum. It is an honor to present the study services at the primary healthcare level in rural areas of Basra. Antenatal care includes preventive and curative care services delivered during pregnancy. WHO recommends that pregnant women receive antenatal care at least 4 times, comprising of vaccination, screening of infections, and identification of danger signs of pregnancy. Access to antenatal care is quite limited in most developing countries, and antenatal care use is often reported to be low. This picture is further worsened by the fact that about 94% of maternal deaths occur in low and middle-income countries, and most are preventable. The study objectives were to describe the current situation of antenatal care use among women attending primary healthcare centers in Basra, to determine association of antenatal care utilization rate with socio-demographic characteristics, and determine barriers to the utilization of antenatal care services in Basra. Methodology. The study design is a descriptive cross-sectional study carried out during a period of 2 months, extending from the 1st of January to the 1st of March 2020. A total of 322 mothers with children aged below 2 years attending 4 primary health care centers in rural areas of Basra were included in the present study. These primary health care centers were selected purposefully to represent different situations in Basra. the results. Table 1 presents the socio-demographic and obstetric characteristics of study participants. More than half of the mothers were between 20 to 29 years old. And 96% were married, and about half of the mothers have less than 6 years of education. Most of the mothers were housewives, and about 50 of the families, their income was below 500 Iraqi dinar. About 1/3 of the mothers had between 3 to 4 children. And about 1/3 have history of abortion. About 2/3 of the mothers, their last pregnancy was planned. And less than half of the mothers, their first antenatal care visit was in the first trimester. Only 39% of the mothers have the recommended or received the recommended 4 visits antenatal care. Table 2 shows association of the frequency of antenatal care services with the socio-demographic and obstetric characteristics of the study participant. As we noted that no significant association was found between antenatal care. There was no statistical significant association between antenatal care visits and mother's age, mother's education, the time taken to reach health facilities, and history of abortion, while there was statistical significant association between the antenatal care visits and mother's occupation, family income, number of children, and pregnancy planning. Table 3 shows barriers experienced by mothers to utilization of antenatal care. Before arrival at the primary health care center, the barriers were preference of private medical care, the most common barrier, followed by difficult to leave elder children. No one can accompany, laziness and forgetfulness. At the primary health care centers, the barriers were long waiting time, lack of essential equipment and supplies, and unavailability of drugs. Conclusions. This study found that antenatal care services in primary health care centers were underutilized. Just 39% of pregnant women received the recommended 4 or more antenatal care visits. Preference of private medical care was the most mentioned barrier. Recommendations. We propose that future efforts in Basra should focus on how to improve husband-family full support for the increased involvement in antenatal care, ensure a good patient-provider relationship, and perceived quality of antenatal care in Basra, especially in rural areas. Thank you.
شكرا جزيلا. The next presentation will be for Jana Drug Company. بس ما ذاكرين منو اللي يقدم الاسم. ماكو أحد من جانا دراج كومباني؟ لا جانا دراج كومباني أكو قبل آية. ماكو يعني. So the next speaker is آية الرباعي, Assistant Lecturer in the Department of Community Medicine, Basra College of Medicine. She will present the results of her study of epidemiology and risk factors of atopic dermatitis among children in Basra.
Thank you for this opportunity. I'd like to present my research, which was part of my master's degree thesis, which is titled as Epidemiology and Risk Factors of Atopic Dermatitis among Children in Basra, Iraq. The study was supervised by Professor Asad Al-Yassin. Starting with a brief background, atopic dermatitis is defined as a chronic or chronically lapsing inflammatory skin disorder. It is usually associated with a personal or a family history of atopy, which is a triad of atopic dermatitis, allergic rhinitis, and asthma. Atopic dermatitis is considered as a major public health problem. It has a financial burden at family and community levels. It affects up to 20% of children worldwide and up to 3% of adults worldwide. Starting with the methodology, the study was a cross-sectional study that was conducted at the period extending from 1st of December 2020 to the 1st of March 2021. It was conducted at the dermatology outpatient clinics of Al-Fayha Teaching Hospital in Basra. The sample size was 104 children who were diagnosed with atopic dermatitis. They were satisfied the Hanfin and Rashka diagnostic criteria of atopic dermatitis, and they were aged less than 16 years. Each patient, the parent of each patient were engaged into a direct interview with the researcher in which a questionnaire that was specifically designed for the study was used. It covered the socio-demographic as well as some of the medical history of these patients. Clinical examination included confirming the presence of the diagnostic criteria, as well as assessment of the stage of the disease, whether acute, subacute, or chronic, and to estimate the body mass index. In addition to that, the severity was assessed using a special tool which is called the objective scorer. As a result, the prevalence of atopic dermatitis among children attending to the dermatology outpatient clinic was 21.3 per 100 population. This was quietly similar to the prevalence of atopic dermatitis in a previous study that was done in Jeddah, Saudi Arabia, with the prevalence of 20%. Secondly, the patients were divided into 3 age groups according to the clinical presentation: the infantile, the childhood, and adolescent. The infantile atopic dermatitis represented a prevalence of 14.7, followed by 21.1 for the childhood atopic dermatitis and 12.1 for the adolescent age group. This was slightly higher than a previous study that was done in Basra, titled as Atopic Eczema Dermatitis Syndrome. While the sex-specific prevalence rates, there was a slightly male predominance with a prevalence of 23.7 compared to 19.1 among the females. This table shows some of the socio-demographic features of the patient. There was a slightly male predominance with a prevalence of 52.9. Regarding the place of residence, most of the individuals were city center inhabitants, and they represented about 68%. Regarding the family side, large family size was considered if there is 6 or more household members, and they represented 75%. Regarding the maternal education, mothers with an education of less than 12 years, they represented about 80%. Children who were breastfed represented 49.3%, and those who were exposed to passive smoking represented 73.1%. And positive family history of atopy was seen in about 90% of the patients. The body mass index, regarding the body mass index, although the majority had normal body mass index with about 78%, however, the overweight and obese children represented a percentage of about 21% collectively. Regarding the clinical characteristics of the patient, early onset of the disease was seen in about 87%. Winter and autumn exacerbation was seen in about 1/2 of the patients. Most of the parents of the children were able to recognize at least one aggravating factor, which was seen in about 72%. And according to the stage, the subacute dermatitis was seen in about 60% of them. Regarding the severity, the moderate atopic dermatitis represented the major category with 83.6%. In this table, we demonstrated association of the severity of atopic dermatitis with some of the clinical parameters. First was the age of onset, the gender, the family history of atopy, the body mass index, the type of feeding, as well as the exposure to passive smoking. There was no statistically significant association between the severity of the disease and and all of these clinical parameters. In this diagram, it shows a comparison between the prevalence of atopic dermatitis in the current study, as well as the prevalence of atopic dermatitis in the previous studies that were done in Iraq. The prevalence of atopic dermatitis has raised from 8.5% in 1997 up to 21.3% in the current study. This increase may be explained by the rapid urbanization, the improvement in the hygienic standards, the exposure to new pollutants, as well as the high rate of consanguine marriages in our area from genetic point of view. In conclusion, about 1/5 of children who attended to the dermatology outpatient clinic were diagnosed with atopic dermatitis, and the true prevalence of atopic dermatitis may be underestimated, as there are mild cases that may not seek medical advice, and there are cases that are treated by over-counter medication, patients treated in private sectors, and patients treated at primary healthcare centers. We recommend further large-scale community-based studies to estimate the true prevalence of atopic dermatitis with emphasis on preventive measures. Thank you for your listening.
شكرا جزيلا. The next presentation will be presented by Assistant Professor Rafid Adil Abboud, who is consultant hemato-oncologist. He's a representative of AstraZeneca. He will present talk about diagnosis and management of EGFRM and SCLS. The last talk. طبعا شكرا كل اللي قدموا والتزموا بالوقت، واقل من الوقت فلهذا يعني we are safe، يعني احنا ويا الوقت نخلص ان شاء الله.
Assalamu alaikum, everybody. Thank you, Mr. Chairman. Thank you, Mr. President. My subject today about subtype of non-small cell lung cancer, who are EGFR positive. The treatment of CA bronchus passes through many steps. At first, the lung cancer considered as a single disease, then subdivided into small and non-small cell lung cancer, and this non-small cell lung cancer further divided into large adenocarcinoma and squamous cell carcinoma. Till the 19th of the recent century, developing the molecular pathology and the targeted therapy in the non-small cell lung cancer, and then finally, and most importantly, the immune therapy in the treatment of bronchogenic carcinoma or non-small cell lung cancer. Around 50% of patients with advanced non-squamous cell carcinoma of the bronchus have a driver mutation or actionable driver mutation. I mean, 50% of the patients have a mutation and they have a treatment for this mutation. And what is the benefit of that? The collection of data of multiple studies and real-world data show that those patients who have actionable mutation have a better survival and overall survival benefit in comparison with those patients with non-small cell lung cancer and without any actionable mutation. So if we have a mutation and we have a drug for this mutation, the survival for those patients is better. Regarding the EGFR mutation, which is one part only of this many actionable mutations, it constitutes about 20 to 30% of non-small cell cancer. And these percentages are higher in those patients are never smoker, Asian people, and those patients with adenocarcinoma or female women or females. Those patients can reach the percentage of EGFR positive till 50%. Usually the mutation or site of the mutation is between the exon 18 and the exon 22. And the majority of these mutations are located in the exon 19 and exon 21. Around 84% of the mutations are located in exon 19 and 21 mutation, and these are usually responsive very well to tyrosine kinase inhibitor. Also, there is a small percentage, around 6%, are exon 20 positive, and those are usually not responding and resistant to the oral therapy tyrosine kinase inhibitor, and they use or we use the chemotherapy for those patients. What is the EGFR? It is a surface receptor. Their activation can lead to the proliferation, invasion, increasing the angiogenesis, and metastasis of the tumor cells. So inhibition of this receptor by tyrosine kinase inhibitor can lead to inhibition of the invasion, angiogenesis, proliferation of the tumor cells. We have till now 5 drugs, 5 tyrosine kinase inhibitors. The first generation is the erlotinib and gefitinib. The second generation, afatinib and dacomatinib. And the third generation and the recent and most powerful is the osimertinib. Usually these drugs are a tyrosine kinase inhibitor, and most of them are working against exon 19 deletion or exon 21 mutation, except the afatinib, which has a wider range and more action against different type of mutation in comparison with the others. Usually the erlotinib and afatinib are reacted with the diet and should be taken on empty stomach, and the other not affected by diet. And the osimertinib, which is the third generation, have very high concentration in the CNS in comparison with the others. Therefore, it can be used for those patients with CNS metastasis. What is the evidence for using of these drugs in patients with the CA bronchus? We have a lot of studies comparing different types of the tyrosine kinase inhibitors, different oral therapy in comparison with the usual previous chemotherapy. And all of these studies show that there is improvement in the progression-free survival in favoring the use of these oral therapy in comparison with the chemotherapy. So we have an oral therapy, less side effects, and better progression-free survival in comparison with the chemotherapy with a lot of side effects. The median overall survival of all these studies are equal and not significant. We'll discuss just 2 studies from these. The first one is IBAS study and included 1217 مريض, يعني large trial for those patients with stage 3 advanced, locally advanced CA bronchus or 4 non-small cell cancer, and for the population were divided into 2 groups. The first group is the use of the oral therapy gefitinib in comparison with the use of the usual chemotherapy اللي متعودين عليه paclitaxel carboplatin. And the primary endpoint is the progression-free survival, and the secondary endpoint is the overall survival, overall response rate, and the quality of life, which is important on those patients. طبعا this study shows that those patients who have an EGFR mutation have a better and significant progression-free survival in comparison with the chemotherapy with very significant p-value. So if the patient have EGFR mutation, it's preferable to use oral therapy gefitinib in comparison with the usual chemotherapy. For those who have negative EGFR mutation, the chemotherapy is better than gefitinib and with significant p-value. So these drugs are indicated for EGFR mutation. Second study or TAP study comparing erlotinib is the another tyrosine kinase inhibitor in comparison with the chemotherapy for patients with stage 3 or 4 non-small cell lung cancer who are EGFR mutation. In the previous study احنا اخذنا all patients وبعدين سوينا لهم subdivision. In this study just we take those patients with EGFR positive and the primary endpoint also progression-free survival. The secondary endpoint is the overall survival, the side effects, safety, quality of life. And also the oral therapy with erlotinib is better than the usual chemotherapy with all its side effects with significant p-value in comparison with the chemotherapy. What about the overall survival? All studies show no overall survival benefit comparing the use of oral tyrosine kinase in comparison with the usual chemotherapy till now. Regarding the progression-free survival and the type of mutation, is there a difference in the response? Does the exon 19 is better with a response with the treatment or exon 21 is better? These studies show that the exon 19 have a better progression-free survival in the comparison with the those with exon 21 mutation. The important question, if we compare the second generation or third generation of tyrosine kinase with the first generation, is there any difference in the efficacy and safety? The first trial comparing afatinib in comparison with gefitinib in patients with who are EGFR mutated lung cancer stage 4 or 3 locally advanced, and the studies were negative. There is no difference in the progression-free survival, no difference in the overall survival between the recent or second generation tyrosine kinase in comparison with the first generation tyrosine kinase. The second study is the phase 3 FLORA study comparing osimertinib, which is the third generation tyrosine kinase inhibitor, in comparison with the erlotinib in those patients with advanced CA bronchitis with EGFR mutation, and the number of the patients is large number, 550 patients, divided into two groups. And this study shows that the third generation tyrosine kinase inhibitor have a better progression-free survival and better overall survival with significant p-value and nearly 19 months. Yani you keep the patient without chemotherapy with good response in median 19 months without treatment, with oral therapy only. The overall survival is also significantly higher with the use of the third generation osimertinib in comparison with the erlotinib. Regarding the side effect, osimertinib is more tolerated, have a less side effect, less dermatitis acneiform, which is usual complaint of the patient with tyrosine kinase inhibitor, have less effect on the liver function too. So we have a new generation with less side effect, with better progression-free survival and better overall survival. Therefore, the last guideline in 2022 show that the preferable treatment is osimertinib as the first line, and other preferable therapy is erlotinib, afatinib, gefitinib, or dacomatinib in those patients who have EGFR mutation positive. We have a problem in the treatment of those patients, which is the CNS involvement, and does these drugs passing the blood-brain barrier or not? And as we know, the CA bronchitis is one of the most common disease that lead to brain secondaries. Around 30% of patients with lung cancer developing lung secondaries at the time of presentation. It's just after the melanoma. Melanoma is the first one, and the second is the adenocarcinoma of the bronchus. If we have to answer to this study, it's also by FLORA study. It showed that the osimertinib have a better progression-free survival in comparison with the erlotinib in treating those patients with brain secondary non-small cell lung cancer. CNS progression occurred in 6% only of those patients with osimertinib in comparison with the 15% with those in the third generation tyrosine kinase inhibitor. Regarding the mechanism of resistance, after using these treatments, most of the patients or all of the patients will develop the resistance sooner or later, and this is the المشكلة اللي راح نواجهها. And why those patients developing resistance to these drugs? The cause for this resistance is developing of a mutation, another mutation that leads to resistance of these drugs. Either there is histopathological mutation, يعني هو المريض كان adenocarcinoma ممكن يتحول حتى إلى squamous cell carcinoma or small cell carcinoma, or there is an existence of a new mutation, KRAS mutation, MET mutation, BRAF mutation إلى آخره. يعني هو المريض بدأ بشيء بس because of using the drug and continuous using of the drug راح يصير في another mutation. وهنا هاي المشكلة اللي راح نواجهها، لأنه ممكن يتحول إلى another يعني after progression ممكن يتحول إلى another disease، يتحول إلى squamous or small cell, and he needs another treatment as well. The management of those patients is somewhat difficult and needs further staging and new biopsy for all patients with the progression. This biopsy is needed to study if there is any histological transformation or new gene mutations that occur in this patient. Regarding the treatment is also a difficult situation, but we can continue on same treatment if the patient is asymptomatic. And if the patient asymptomatic, we can continue on the same treatment. If the patient develops CNS involvement, we can treat locally by gamma knife or radiotherapy, and we continue on the same treatment. Or if the patient develops مثلا histological transformation، هنا لازم نغير treatment للألكول. يعني إذا كان small cell ممكن نستخدم cisplatin tuberosity or sequential treatment, or you can treat the genetic mutation that occur in this patient. One of the common, around 25% of those patients who have developed mutation develop it at the level of T790M mutation, and this study comparing the use of osimertinib in comparison with chemotherapy and those patients who are previously taking tyrosine kinase inhibitor, and osimertinib as a second line is better than chemotherapy with significant p-value regarding the progression-free survival. Just 2 minutes. دي بس هاي النقاط مهمة. يعني احنا احيانا يعني هذا المريض just 2 patients. This is patients with CA bronchus treated with osimertinib for 10 months and then develop a progression. Now سوينا له another biopsy and there is ALK fusion mutation. يعني in addition to the EGFR develop ALK mutation. احنا usually we can shift to the ALK treatment or ALK inhibitor, but the combination of two drugs osimertinib يعني يبقى EGFR inhibitor plus the ALK inhibitor crizotinib give us more survival and more benefit 8 months, and if there is progression we can shift to alectinib with the combination with the osimertinib, and we get another 10 months. In conclusion, we can take 28 months without chemotherapy. And this is another حتى نقارن ويا patients with CA bronchus with erlotinib only يعني on erlotinib and develop progression. We shift him to the osimertinib. The patient develop rapidly progression, only to 2.4 months progression-free survival. But when we use the crizotinib also 1.9 months only, we get 1.9 and progression. But when we use the combination osimertinib plus crizotinib, we get 13 months. And this means that some of the tumor cells still responding to the EGFR, some of the tumor cells are mutated to the MET, and we can use both of them. Take-home message: the EGFR mutation is one of the mutations that can be used as treatment in the patients with lung cancer. The usual mutation occur at the exon 19 or exon 21, and the first, second, and third line of the tyrosine kinase inhibitor can be used on those patients. The best one for the first line or second line is the osimertinib with 19 months progression-free survival, a more efficacy regarding the CNS involvement. The afatinib can be used in some or rare mutation of the EGFR, and after failure of the first line, we have to take biopsy and detect any mutation. And thank you.
Okay, شكرا جزيلا. Now we have 10 minutes for discussion. يعني ما نحدد عدد أشخاص، عدد الأسئلة، نحدد الوقت. فإذا أكو سؤال. تفضل دكتور. سؤال إلمن. أوكي.
الموضوع معقد أشتيدك كل مرة مو مال end of session. EGFR مو كل السي علاج هي EGFR بوزيتيف أشتيدك يعني 10% واكو ريسبونس وحبايه والمريض نقول له اعطيك حبايه يقتنع مو كيموثيرابي يوقع شعرك تنزل مناعتك. الثيرد جنريشن هسه من التوكس مالتك انه الثيرد جنريشن ممكن نستخدمه كفيرست لاين، ممكن نستخدمه من يصير بروجريشن اوف ذا ديزيز مو بالفيرست لاين طتنا هواي ديزيز فري سرفايفل مو بس من يصير بروجريشن هي سلاحنا الثاني راح يصير. فالجايد لاين شو تقول؟ اوزمرتلب شو يصير؟ فيرست لاين لو خليه للبروجريشن.
الجايد لاين لو احنا شو نسوي هنا؟
احنا شو نسوي؟ يلا بعد احسن.
الجايد لاين is the osimertinib is the first line مثل ما شفنا because it gives a 19 month progression free survival which is very long duration نعتبر لان هو الميديان survival of patient في lung cancer اصلا هو 10 to 12 بس هنا اذا جايد لاين فهو first line بس احنا هنا ايش نستخدم؟ أنا بالنسبة لنا المتوفر هو الفيرست جنريشن أو كان يوز جيفتينيب and erlotinib and keep the second osimertinib for progression after failure of the first line. وطبعا in the second line osimertinib will give us 10 months. وبال first line يعطينا 19 months. In the second line 10 months.
وعادة من يصير بروجريشن احنا ما نسوي ريبايوبسي مو؟
والله احنا نسوي أول شيء liquid biopsy liquid for يعني serum for T790 mutation. If it is negative, we take a biopsy. If it is positive, we go for Tagris or the
شكرا.
شكرا. سؤال آخر. بين تعبتوا؟ تفضل. دكتور حسنين. الأفضل. خلي دكتور سعد. دكتور سعد راح يسأل سؤال. دكتور رافد.
We don't have a study regarding our result.
يعني
نعم يعني
ما استعملتوا انتم
نعم
مرضانا؟
نعم.
Why we are not depending on our result because as we mentioned
بالنسبة لنا يعني احنا result
عندنا مالتي سنتر عمارة
بالنسبة لنا result for these tyrosine kinase is very encouraging. يعني تحس بيه كأنه magic response.
How many patients you use?
مسجلين عندنا لحد الآن قاعد ياخذون علاج حوالي 15 يعني بس in time هسه حاليا 15 مريض. أخذ جزء مثلا قبل سنة كانوا إذا تجمعهم accumulative لا يجوز يوصلون يعني large number.
So we want the results of this large number please.
شكرا. دكتور سؤال.
We have a patient يعني هسه عندنا patient 5 and 6 years هو سير 5 6 تابلت or يعني بعد 6
هو بس قبل لا ينزل دكتور رافد اكو إلى سؤال بعد؟ اوكي دكتور حسنين استلم الميكروفون.
Dr. Hassanian, I thank you very much for your presentation. You mentioned in your study and your discussion that there was excess of death of male, and that is death of male more than female. Could you please tell us about the reason, about the probability of reason? I mean, thank you.
Yes, sir. Yes, sir. The excess of male death is concomitant also with other study, either for the first thing, other study, most studies I read it, it's agree with me in this. In our society, I think that male is more working than the female. So, stress factor, exposure to radiation, exposure to smoking, exposure to a lot of risk factor, make them more likely to be dead than female. Besides that, and during this period, we pass through the war against Daesh, and this also spent a lot of them from our society. That's one.
Okay, thank you very much.
شكرا. اكو سؤال اخر الدكتور حسنين؟ ماكو؟ شكرا. اكو اي اسئله بعد اخرى؟ انا فقط كومنت على دكتوره آية. بالنسبه الى يعني كومنت مو سؤال. البريفالنس يعني استخدام مصطلح البريفالنس عندك بالدراسة مو صحيح لأنه هذه this is the proportion of attendants to the dermatology unit who have atopic dermatitis. يعني prevalence denominator should be the age specific population. بس هذه الملاحظة. ودكتور لؤي يمكن هو طلع عنده كانت في النتائج العرض النتائج النسب مئوية ما حاسبها مضبوط يعني يعني كاتجاه. وبالنسبة للدكتور سامح يعني أنت يعني العرض مالتك أنت قلت systematic review بس أنا ما شفت أكو indicators for the deterioration in the care يعني ما عدا دراسة الدكتور عباس ذكرت لنا أنه هيك صار بها يعني اعطيتنا أرقام البقية كديزاستر يعني disasters والwars وغيرها يعني تصير deterioration in all aspects of life وكل الميديكال كير يعني مو بس الدايبيتيك كير بس هل عندك يعني indicators for the deterioration يعني طيتنا يعني
اوكي
احصائيات يعني زياده الكومبليكيشنز hospitalizations مالت المرضى الوفيات الدايبيتيك
كل هذه الامور اللي قلتيها جنابك موجوده بالدراسه الاصليه الدراسه كانت جدا عاليه الدراسة هي invited by the chair of the IDF for us to do this study systematic review وإنه نضمن كل الكونفليكتس اللي موجودة من أفغانستان إلى حد موروكو الكونفليكت سواء ميليتري أو natural disasters خلال هاي الفترة اللي هي من 2000 إلى 2022 الدراسة فيها كلش كبيرة عبارة عن 13,000 كلمة تقريبا وياها جداول كلش هواية إن شاء الله راح أنا ما أقدر
أعلى مستوى من
أنا ما أقدر أعرض كل الأمور اللي موجودة إن شاء الله بشهر العاشر في لشبونة راح تنعرض الدراسة كاملة وبالرباط أعتقد بشهر التاسع إن شاء الله راح نعرضها بس الدراسة كاملة كساعة ونص ككينوت لكتشر إن شاء الله
يعني أكو يعني
يعني هي إن شاء الله من تنعرض إن شاء الله راح published in the next month بس هي إن شاء الله بلشبونة وبالرباط بشهر العاشر بشهر التاسع بس ساعة ونص مو 10 دقائق
شكرا جزيلا الدكتور فائزة المن سؤال السؤال المن دكتور comment
thank you so much for all speakers and my comment is for Dr. Juhud about the barriers to antenatal care. يعني I just want to present myself. I used to work in this Basra 20 years back more and I used to be the director of maternal child health at the primary health care.
دكتور الكل يعرفوك بالبصرة
يعني 24 years back we used to present the same reasons for barriers for antenatal care. And today we are in 2022, we are still reflecting the same reasons. So why is this happening? We need to know. Still the people don't go because of the crowding, long waiting. So why we are not putting some solutions for this? I think we need to study this point. And the second point is that I don't know whether in Basra you are using still the 4th plus antenatal care, because the new WHO model, and I am a person that worked with WHO Health Office for 8 years. The 2016 model for antenatal care is 8 visits during first, second, and third trimester. And this is, as you know, any WHO model, it will not come up only after evidence-based 5-year study. And they saw that this model will reduce perinatal mortality. So I don't know whether in Basra or in Iraq, are you using the 8?
At least
or
for,
are you still sticking to the 4th antenatal visit
at
plus?
least for
And this is my really comments, and I wish you all the best. Thank you.
شكرا دكتورة فايزة.
So are you using the 4 or the 8?
at least for visit.
بالنسبة للمراكز الصحية والمشكلة اللونج ويتنج تايم، هو احنا ما عندنا ترتيب، عندنا تنظيم الوقت. يعني لو يعطون ابوينتمنتس للنساء كل واحدة تجي بوقت معين، لأنه دائما يجون البولك بين 9 والعشرة ونص 11 بعد وراها تفرغ المراكز.
دون appointment.
يعني هو التنظيم، تنظيم أكثر شيء. إذا ماكو سؤال، إذا ماكو بعد سؤال نشكر الحضور وشكرا جزيلا ونختم الجلسة. شكرا جزيلا.